Bismillahirrahmanirrahim. Hi everybody. So in this video of the POCUS series, I will attempt to quickly review how POCUS can be really useful in pericardial tamponade, and also I'll try to explain the findings in a simple way. Okay, so let's get into it. As you know, there is no single diagnostic test for pericarditis. The European Society of Cardiology advocates for 2 criteria out of 4 diagnostic criteria for acute pericarditis, which include the pericardial chest pain, the pericardial friction rub, the characteristic ECG changes, and new or worsening pericardial effusion. So that criteria, as you can see, includes 1 physical examination finding and 1 ultrasound finding. So we'll talk about these 2. So pericardial friction rub might be difficult to find since it's not present in all cases and need careful examination to be detected. So it's found in about 35% to 80% of patients. It's described as being evanescent or inconsistent, meaning you examine the patient now and you hear the rub. You examine the patient later and no rub is found. I will ask and challenge you to look around and search for other physical examination findings that are classically described as evanescent other than the pericardial rub. If you find it in the appropriate setting, it's almost pathognomonic. It is described as high-pitched, harsh sound resembling walking in a dry snow. Always remember that during auscultation, your stethoscope has both a diaphragm and a bell. The diaphragm is for high-pitched sounds and the bell for low-pitched sounds. Not all cardiac sounds are created the same. So for the pericardial friction rub, use the diaphragm for a better yield. Apply the diaphragm firmly to the chest, and the best location might be between the apex and the left lower sternal border, but it can be heard anywhere in the precordium. Ask the patient to lean forward to hear it better. Fortunately, with acute pericarditis, that position usually makes chest pain better, as you know. So, take advantage of that. It might also be heard better during expiration, but it can be louder during expiration as well. And you can hear it during systole, during diastole, or sometimes in both. Just for fun, Ewart's sign was traditionally described in large pericardial effusion. It's basically due to collapse of the left lung base by the fluid in the pericardial sac. So during lung examination, you might find dullness and bronchial breathing below the angle of the left scapula, but that does not indicate a primary lung problem, but it's due to a very large pericardial effusion, usually described as a water bottle sign in chest x-ray. Water bottle heart or globular heart can be due to many causes, but large pericardial effusion is one of them. Moving to point of care ultrasound or POCUS, as you can see in this long axis and short axis left peristernal views, new or worsening pericardial effusion can be a sign of pericarditis in the appropriate setting, and thus points towards the diagnosis. It's always a good idea in ultrasound to confirm a finding with more than one view. So here the pericardial effusion is represented by the red dots, and classification of the size of pericardial effusion to mild, moderate, or large depends on the measurement of the widest diameter of the effusion in ultrasound. Tamponade is both clinical and radiographic or cardiographic diagnosis. The clinical diagnosis needs a high index of suspicion as the clinical features are not specific. Rapid accumulation of small amount of effusion can compromise the heart in comparison to more slow accumulation, which gives time for the heart to adapt. Tachycardia and hypotension might be present. Although a patient with history of hypertension, they might not be hypotensive. Blood pressure might be normal or even a little bit high. JVD might be elevated with the X descent more clearly seen. The X descent is an inward movement and usually occurs during systole. So it should be easily differentiated from arterial pulse, which is an outward movement seen in the side of the neck during systole. Fluid around the heart will attenuate the heart sound, so heart sound might be muffled. These three signs, as you know, are called the Beck's triad. Beck was actually a cardiac surgeon who described these findings in patients with complications after heart surgery. So you can imagine that these features are more expected to be seen given the acuity of tamponade, which can happen after surgery. But nowadays, we know that pericardial effusion can have many causes, and not all of them can produce the Beck's triad. So in fact, the three signs can be all absent, in some patients, and some patients might have one or two of them. The last interesting sign is pulsus paradoxus or paradoxical pulse, which is not actually a paradox. There's nothing paradoxical about having an exaggeration of a normal physiologic fall of blood pressure during inspiration. We are going to discuss this sign in more detail, but basically it's if there is an exaggeration more than 10 millimeter of mercury of the normal physiologic fall of blood pressure during inspiration, this is what defines pulsus paradoxus. So I know it's called paradoxical pulse, but it's actually measured during manual blood pressure measurement. We in medicine love to make things complicated, right? The basis of this sign and other echo or ultrasound findings, as we will see in the next few slides, is a variation of cardiac output during respiratory cycle. So simply put, inspiration will increase the venous return to the right heart, and this extra blood and pressure will shift the septum to the left heart, and that will lead to reduced left ventricular filling and thus reduced contractility and reduced cardiac output. So for example, in this patient who had a systolic who had a blood pressure of about 100 over 110 over 70, when you inflate the sphygmomanometer cuff to a pressure more than 110, then no cortical sounds will be heard, and you will continue to deflate the cuff until you reach 110, and then you will hear the first cortical sound, or K1, but at the beginning you will hear that only during expiration, because remember, during inspiration the cardiac output is reduced and there is no sound will be produced. So this will be the systolic blood pressure, and then you continue to slowly deflate the cuff until you start to hear the cortical sounds during both expiration and also during inspiration, and then you will note that pressure. What will you do is you will subtract the pressure when you hear the cortical sounds during both expiration and inspiration, which is in this patient was about 90. You'll subtract that from the systolic blood pressure, which was 110 in this patient, so it's 110 minus 90, so that will give you 20. So normally the physiological response is the normal physiological variation should be less than 10, but if it's exaggerated, if it's more than 10, and especially if it's more than 12, that what defines pulsus paradoxus, or that will define pulsus paradoxus, and cardiac tamponade could be one of the causes. So again, in this demonstration of another example, you should start to inflate the sphygmomanometer curve until no chord cough sounds are heard, and then you start deflating slowly until you hear the first chord cough sound, K1, and you should hear that during expiration only at the beginning. So in this case it was 100, so this 100 is this patient's systolic blood pressure. So you will note that pressure, and then you will continue to deflate slowly until you hear the chord cough sounds in both expiration and inspiration, and you will note that pressure also, and in this case it was 88. So you subtract this pressure 88 from the systolic blood pressure 100, and that will give you 12. So 12 millimeters of mercury, it's more than 10. It's more than the normal exaggeration of the physiologic response during inspiration or respiratory cycle. So this defines pulsus paradoxus. In one small study, they found that pulsus paradoxus has a sensitivity of 98% and specificity up to 83% if the pressure is really high, like more than 12. But the patient population is a small study. They really had a high pretest probability because it was done in patients suspected to have pulsus paradoxus, because the study was done in patients referred for consideration of pericardiocentesis, and that's why the sensitivity and specificity, I think, and the likelihood ratios might be really exaggerated and inflated. In another study, they found that the pulsus paradoxus has a sensitivity of 80% and a specificity of 40%, which I think is is a more reasonable estimate. But as you can see, the pulsus paradoxus is not 100% specific, so it can be seen in other conditions like constrictive pericarditis, restrictive cardiomyopathy, right ventricular infarct. It can also be seen in extracardiac conditions or pulmonary conditions like asthma and COPD, severe pulmonary embolism, and also any cause of severe hypovolemic shock can give you pulsus paradoxus. And in each of these conditions, it's associated with own pathophysiology. So keep that in mind. And also, absence of pulsus paradoxus doesn't, of course, rule out tamponade. And as you can tell, it might be a little bit difficult to elicit, especially with the fact that we rarely do the manual blood pressure measurement these days. But I think it's still a good sign to practice.